Assalamu alaikum. It's a continuation of the CSF form emergency medicine. Start with my intro, where you will hear a murmur. Can you tell me the name of this murmur? Okay, okay, question number 36. So, the an otherwise healthy 37-year-old man is brought to the emergency department, for lower back pain. Lower back pain, not radiation, just lower back pain starts due to uh, lifting a heavy box or furniture one day ago. In that perspective, you do not, and it is done for a day. It has been happened for a day. There is no neurological problem, so you did not need to do any further testing. So lumbosacral strain commonly occurs following strenuous exertion and is characterized by dull, aching lower back pain that does not radiate, lower back pain that does not radiate to the lower extremity, which is not accompanied by neurological deficits. Most adults with acute lower back pain of less than 1 month of duration do not require imaging, which is limited, limited diagnostic value and leads to unnecessary testing, medical expenses, and radiation exposure. Imaging may be useful for the diagnosis for persistent low back pain, and pain is accompanied by severe progressive neurologic deficits, or pain is suspected to be secondary to a certain disease entities such as vertebral metastasis, spinal stenosis, osteomyelitis, spinal epidural hematoma or abscess, or vertical fracture. Any patient with red flags of back pain such as neurologic symptoms to suggest choroidal or conus medullaris syndrome, history of malignancy, traumatic injury, midline tenderness accompanying fever or infectious symptoms, or history of immunocompromise may benefit from acute imaging. However, most patients with acute lumbosacral strain can be managed conservatively with heat or ice, massage, and light exercise, provided the history and the examinations are reassuring and lacking red flags. Okay, this patient need needle thoracostomy. So this 37-year-old patient 40 department by the paramedics after sustained uh, a stab wound. This is very stab wound, and the common stab wound uh, and his respiration is higher, BP is lower, hypertension, tachycardia, tachypnea. So this actually gives me distracted. These things actually distracts me mm, for finding out the exact answer. Saturation is low. He receives 100% oxygen. Saturation is low. JVP is distended. Hypertension, tachycardia, tachypnea, distended neck vein. These are the clues for a cardiac tamponade. But he has a sustained stab injury. So tension pneumothorax is one of the complications of penetrating thoracic trauma. And the most important is decreased breath sound. This is a very high yield clue that I missed. I am just going through the clues of cardiac temperament, but the typical two important clue that I have missed, like these two clues, like one is decreased breath sound, decreased breath sound, decrease breath sound. And the next clue what I missed is a stab injury. Stab injury. So tension pneumothorax is the number one differentials you should keep in the mind. Okay, next. Okay, why I missed this question? I don't know. I need to find out. So this patient showing brainstem dysfunction. Mm, so 1 hour after losing consciousness while eating at home. The 72 were 1 hour after losing consciousness while eating at home. Mm, on arrival, she is intubated, mechanically ventilated because of poor respiratory effort. BP is higher. There is overriding of the ventricular ventilator with the respiration is 14 per minute. For respiration is 14 per minute. Respiration is 14 per minute. Okay, this patient showing the brainstem dysfunction including altered level of consciousness, poor respiratory effect, posturing, negative oculocephalic maneuver on examination, negative. So there are no horizontal eye movement on spontaneous doll's eye or oculocephalic maneuver. So negative mm, oculocephalic maneuver. So there is no horizontal eye movement. There is no horizontal eye movement on or doll's eye maneuver. And oculocephalic maneuver. So and negative oculocephalic maneuver. So brainstem dysfunction. So altered level consciousness, poor respiratory effort, posturing, and negative oculocephalic maneuver on examination. Dysfunction of the brainstem can present with cranial nerve dysfunction, dizziness, vertigo, gait instability, and that the patient had been experiencing prior to the acute episode. The Babinski sign or plantar response that indicates the damage to the corticospinal tract and descending motor. The Babinski sign is present on the lateral part of the plantar surface of the foot and firmly struck by the hallux stentoprostrally. The doll's eye maneuver refers to brainstem reflex that occurs in normal adult, in which the examiner moves the patient head and the eye moves on the opposite direction. The eye move in opposite direction to hold the eye move the opposite direction to hold the patient's gaze on that object. In negative oculocephalic reflex, the patient's eye remain midline, which indicates the patient's eye remain midline, which indicates severe brainstem dysfunction. This causes brainstem dysfunction in this patient, likely brainstem ischemia, which is not often disclosed on CT scan. Where MRI is more sensitive for diagnosis. Patient with brainstem ischemia can have stuttering course, which patient experience with mild intermittent symptoms prior to this presentation. So negative oculocephalic reflex is negative oculocephalic. The doll's eye or oculocephalic maneuver refers to brainstem reflex that occurs in normal adults, in which the examiner moves the head, in which the examiner moves the head and the eyes move in the opposite direction. The eye moves in the opposite direction. Mm, In to hold the patient's gaze on that object. In negative oculocephalic reflex, the patient eye remain midline. The patient eye remain midline, which indicates severe brainstem dysfunction. Okay, that's it. So brainstem ischemia. There are no horizontal movements spontaneously or Dolce movement maneuver. So these patients negative oculocephalic maneuver on examination and altered level of consciousness, poor respiratory effect looks like brainstem ischemia. Okay, this is wrong. Allow the patient to leave against medical device. So patients are in here. What happened? Motor vehicle collision in which he has restrained driver. Examination showed tenderness and swelling in the right elbow. The physician recommends that X-ray of the elbow be performed. X-ray of the elbow be performed. The patient says he want to prefer to leave. He is able to verbalize the risk and leaving using his own words. Which of the following is the most appropriate step? Patient's autonomy is one of the four medical ethics. Allow the patient to leave against medical device. Um, Along with beneficence, non-maleficence, and justice. Autonomy poses that patients have the right to make their decision provided that they have the capacity to do and they have been provided with appropriate information for making in such a decision. A consenting adult with the decision making capacity has the right to refuse some or all of the medical condition if such a decision may result in short or long term morbidity or mortality. In case patient is declining further workup and treatment of the musculoskeletal injury mm, induced by motor vehicle collision, provided that the patient has the capacity and the caring physician has explained the benefits, risk, and alternative. Okay, so allow the patient to leave. Okay, this is a very high yield question. Okay, 54-year type 2 diabetes brought to the emergency department. Paramedics 30 minutes after his wife found him lying unresponsive on his bed. His finger stick blood glucose concentration was 21.11 millimole. So he called 911. His medication is glimepiride and metformin. He has no drug allergies at the scene. Paramedics could not obtain IV access and transported him to the on arrival. The patient is diaphoretic, moaning softly, and pulse is 90 per minute. Respiration are 8 per minute, and pulse oximetry this and that. No skin rashes are found. Finger stick blood glucose is 15.83 millimole per liter. The nurse continues to have the difficulty in obtaining. What is the next step in the appropriate management while awaiting for IV access? Give intramuscular administration of the glucagon is the most appropriate step in diabetes patient with severe hypoglycemia and no IV access. The treatment of severe hypoglycemia in uh, excess in diabetic patient require Administration of either carbohydrate or glucagon. If IBXS is available, carbohydrate can easily be given as 50% dextrose. However, in this case, intramuscular glucagon is the first and safe way to reverse hypoglycemia in patients with impaired consciousness and no IV access. After administration of the glucagon, the patient must closely monitor and intravenous access obtained because the effect of glucagon is transient and IV access after IV access is available, a continuous infusion of the glucose will likely to be necessary. Any patient with hypoglycemia taking long-acting oral hypoglycemic sulfonylurea will require prolonged monitoring and or admission because rebound hypoglycemia is common. Okay, okay. Vertebral artery dissection is the on this patient. Vertebral artery dissection is the most common cause of stroke in young in healthy in young healthy patient. So 31 is transfuse as there is a patient is hypovolemic, patient BP is not raising. In addition to crystalloid, continued crystalloid, which of the following is the most appropriate next step? Transfuse type O Rh negative packed red blood cell. That's the thing we need to do. Okay, now 30. Vertical artery dissection is the most common cause of stroke in young healthy patient. In young healthy patient can be caused by spontaneous dissection, or can be secondary to trauma. Even mild trauma such as turning to the quickly turning the neck, exercise, and chiropractic activities can be associated with vertebral artery dissection. Patient can present with symptoms such as neck pain, Horner syndrome, cranial neuropathies, dysarthria, and ataxia. Horner syndrome is characterized by a triad ipsilateral miosis, ptosis, and hydrosis. Horner syndrome can arise from lesion along a sympathetic pathway. Vertebral artery dissection is assessed with lateral medullary. Vertebral artery dissection is associated with lateral medullary infarction or Wallenberg syndrome, characterized by ipsilateral ataxia of the extremity movement, and gait ataxia can be associated with nystagmus, and the dysarthria can be associated with nystagmus or dysarthria. So it is not carotid artery occlusion. It can cause decreased flow to the brain and embolic events resulting in cerebrovascular ischemia. Patient can have carotid bruit on examination. Carotid pulse plaque can embolize to cause ocular ischemia, contralateral hemiparesis, hemisensory loss, and homonymous hemianopia. So vertical artery dissection can cause a stroke in young, healthy patient can be a spontaneous dissection. So there is Horner's, there is Babinski sign is absent, there is tremor. So it's vertebral artery dissection. This is CT angiography. Why this is CT angiography? 2 weeks abdominal cramp after eating. His medical reports from 6 months ago show left ventricular ejection fraction 20%. Cardiopulmonary examination discloses S3 bilateral basilar crackles. Lateral basilar crackles. So CT angiography is the most important next step in the management. The patient with heart failure. So patient has S3 gallo, heart failure with reduced ejection fraction. So CT angiography is the most common. This patient, sorry. So CT angiography is the most appropriate next step in the diagnosis. The patient with heart failure with reduced ejection fraction, his ejection fraction is 20. Heart failure with reduced ejection fraction, heart failure diagnosed by S3, reduced ejection fraction, and recent weight loss postprandial abdominal pain. So he has problem. Is postprandial abdominal pain, recent weight loss, most likely non-occlusive. Mesenteric ischemia. Mesenteric ischemia can occur secondary to the thrombus. Mesenteric ischemia can occur. Mesenteric ischemia can occur secondary to thrombus of the mesenteric artery or can result from low flow cardiac state leading to intestinal hyperperfusion. Leading to intestinal hyperperfusion, the blood supply to the intestine is primarily derived from the superior mesenteric artery and the inferior mesenteric artery. Following a meal, the blood flow to the intestine increases to aid in the digestive process. In an occlusive mesenteric ischemia, in an in non-occlusive mesenteric ischemia, constriction to the constriction of the mesenteric artery in combination with decreased cardiac output leads to supply demand mismatch and subsequent intestinal ischemia. Supply demand mismatch and subsequent intestinal ischemia. This patient often experienced as postprandial pain which may okay. So this is mesenteric ischemia. This one is vertebral artery dissection. Vertebral artery dissection is associated with lateral medullary infarction or Wallenberg syndrome. Ipsilateral ataxia of the extremity movements, gait ataxia, contralateral nystagmus. Okay, next. So this city angiography I have done insertion of the NG tube. This patient should be inserted an NG tube. Bowel obstruction, most likely diagnosis, previous abdominal surgery, abdominal pain, obstipation. Obstruction of the bowel occurs partial obstruction allows a degree of the continuous flatus with diminished stooling. Complete obstruction results in obstruction, no passage of stool or flatus. Obstruction has many potential causes. The most common is post-surgical peritoneal adhesion or hernia. Post-surgical peritoneal adhesion or hernia obstruction has many potential. On physical examination, patients present with abdominal tenderness, distension, tympani to perfusion, borborygmy. Potential complications include bowel rupture, necrosis, which can result in sudden onset peritoneal signs, as well as X-ray show multiple airflow level in the setting of dilated loops. Management requires bowel rest, insertion of the NG tube, compression, IV fluid. If obstruction does not auto-reduce, then the laparotomy option, exploratory laparotomy. Okay, next, it is heat stroke. I don't know why I choose the abdominalis. It's a clear-cut heat stroke. Even if a clear-cut stroke, I choose this for abdominalis. Just looking at the CK level, I got shocked. But heat stroke can cause a high CK. So increased body temperature that occurs when the body is exposed to high environmental temperature, humidity. It commonly occurs in young athletes. It commonly occurs in young athletes or in elderly patients or with impaired thermoregulatory capacity. Vasodilatation of the superficial vessel may lead to marrow failure, including hepatic or renal ischemia. Abdominalysis, disseminated intravascular coagulation treatment include cooling of the patient with fans and or ice, continuous core temperature monitoring, support of airway breathing, circulation, heat stroke. Okay, so this is CT scan of the abdomen for urolithiasis in patients with right flank pain and hematuria. CT scan of the abdomen to confirm the urolithiasis. Okay, next. DNC should be done in postpartum hemorrhage. A significant uterine bleeding. A common cause of secondary postpartum hemorrhage is written product of conception, which can become infected and can cause postpartum endometritis. And if there is postpartum endometritis, it causes fever, tachycardia, abdominal pain, and treatment written product of conception with cervical dilatation and curettage, and the products. This patient would also need to treat an associated infection. Okay, so in here what we'll give in here the features of the hyperthyroidism multinodular goiter. She demonstrates a chronic increase in T4 and 15-pound weight loss. So, features of hyperthyroidism. So the treatment symptomatic hyperthyroidism begins with oral propranolol. Oral propranolol. So decreased cardiac preload. This patient is hypovolemic shock, hypotension, hypovolemic shock, vomiting, hypovolemic shock. So decreased cardiac preload. Okay. So this is the alcohol use, which suicide is the most risk factor of patients with depression. So physician should ask the detailed question about the patient's suicidal ideation, suicidality, woman, mm, any patient moderate or high risk warrants for further trained for psychiatry, psychologist, mental health, or in patients such. So the single strongest predictor for suicide is previous attempt. Other risk factor age over 45, alcohol and other substance use. Mm, age over 45, alcohol, other substance use, chronic illness, and organized plan, or excess or to weapon, or unmarried, being unmarried, being unmarried, lack of social support. So fracture of the femoral neck, osteoporosis. Osteoporosis is a condition characterized by progressive loss of bone mineral density, leading to decreased bone strength. This decreased bone mineral density often leads to fragility fracture, which can lead to decreased mobility. Fracture neck femur is shortened and externally knotted. Measurement of the beta hCG. Women of the reproductive age, beta hCG pregnancy should be excluded. And ibuprofen for acute pericarditis, pleuritic chest pain, leaning forward, ibuprofen. This patient administration of the atropine, like OPC poisoning administration, DK, decreased bicarbonate, DK. So DK patient dysregulated metabolic acidosis accompanied by decreased bicarbonate concentration in the serum because of bicarbonate responsing in the nebulization, in the neutralization of the increased acidic molecule, hydrogen molecule in the blood. Treatment is insulin volume replacement, correction of the electrolyte, and treatment of any. So in DK there may be decreased bicarbonate. So in it results in high anion gap metabolic acidosis, which is associated with decreased bicarbonate concentration. because bicarbonate is consumed in the neutralization in the acidic molecules, hydrogen molecules in the blood. Okay, so in here we will give irrigation of the antibiotic. Closure is never the answer. If somebody has given right, irrigation and antibiotic, closure is never the answer. Okay, so that's all. Surgical concentration for cubic of pain, ultrasonography of the pelvis. So it's ovarian torsion, often ultrasonography of the pelvis. Okay, that's all about the administration neutralize nebulized albuterol. Okay, common bile duct obstruction, even if the MLS is high, but it is due to common bile duct obstruction. Okay, that's all about the CMS from today's session. Hope you will enjoy it. So, and the murmur is aortic stenosis.